StreamYard before. It says I'm live.
There you go.
Hey, y'all. Hey. Happy Friday. We are laughing over here because we have been trying to go live. Ladies, how long have you been trying to go live?
Since what, 6:20?
Since whatever time.
Give or take. Dark outside over here. So I don't know.
Whatever time we were supposed to go live, we were going live. Okay. Hey, whoever is out there, thank you for being patient with us. But I'm telling you, I had this happen once before, and it's like Facebook and Zoom, they get into these little cat fights, and then one doesn't want to let the other one in, and then I try to go live, and they just will not connect. So I can see one side of it, but I can't see the other side. So anyway, thank you guys for your patience this evening. I am super excited. I told Dr. Rania that obviously this is information that needs to get out there because there are forces trying to keep us from going live. But we were like, we gonna do this. This is what Black Girl Magic is. We push through, yes. We persist, and we are here. Yes, ma'am. So I'm glad you are out there with us today. I am so excited about this show because we have two extraordinary experts, literally experts, that are on the show today talking about a subject that is not talked enough about in our community. And I would say it's not really talked about enough with women in general. What is the deal with that? But we are going to talk about it today because I like to talk about the stuff nobody wants to talk about. Let's talk about it. Okay? We're going to be talking about perimenopause and menopause and the impact that it has on both our physical bodies as well as our mental health. And I have two amazing women here today who are qualified to talk to us on both of these subjects. So Dr. Rania has been here before. I don't know why she would agree to come on this show with me again. She knows we're going to come on here and cut up.
That's why I come on.
We're going to cut up, but we're going to make sure while we're cutting up, we are getting y'all the information.
Yes.
You are informed when it's over. But Dr. Rania is here joining us from Columbia, South Carolina. She is a board-certified psychiatrist. She specializes in medication management, adult depression, bipolar disorder, trauma issues, women issues, and she is a passionate speaker on mental health in the African-American community. Why she on this show right here. And also the intersection between mental health and faith. So I am so excited to have Dr. Rania McGee back on the show. What did I forget? Tell me, what is the name of your practice so everybody can know where to find you because they might need you after the show.
Yeah. I am in South Carolina at First Presbyterian Christian Counseling Center. You can always find us too on www.blackpeopletreat.com as well. So.
Yes. And these two ladies, and she jumped the gun, but let's just go ahead and go there. They are entrepreneur extraordinaires who have founded a website called blackpeopletreat.com, where they are aggregating all of the African American and Black doctors and physicians throughout the country, so that when you are looking for a compassionate, caring doctor who understands the trials and tribulations of being Black here in America, you can go to blackpeopletreat.com. So I am excited about these two co-founders that are here this evening that are going to share their expertise with us. And so without further ado, I'm going to introduce my second guest, Dr. Lori Givens-Best. Dr. Givens is here, and she is also board certified physician, but she's an OBGYN. She has tremendous experience in women's health, including births, infertility, menstrual irregularities, menopausal medicine. The list goes on. If it has to do with the female organs, anything dealing with the female stuff, she is the one that can answer those questions. But she's going to use the anatomically correct words. So we're not going to say vajayjay and all those other things. Not appropriate when you are in the presence of an OBGYN. So we about to get a little bit of school here. So y'all, Welcome to the show, Dr. Lori. We are going to have a great time. Is it okay for me to call you Dr. Lori?
That's fine. Yeah.
And let me tell y'all, I went to college with both of them. We graduated together. Lori and I were on student government together. So here we are, 20 years together, back again, here sharing on topics that are of importance to us as women. So y'all, let's just talk about it. I really started reflecting back on just women and everything that makes us feminine, right? From, our breasts to just being voluptuous, having these voluptuous bodies to, periods and babies and menopause. And it seems like there is such a taboo, I don't know, there's just some sort of negative attachment associated with talking openly and honestly about these topics that if you are a woman, there's no question as to whether you're going to experience. You gonna get period if you're a woman. I mean, from what I understand, I ain't no doctor, but from what I understand, for the most part, you falling in that category. If you are a woman, you're gonna likely experience menopause and possibly perimenopause at some point. But how come ain't nobody talking about this? Does anybody have what is the deal? Because I missed out on a lot of information.
I think as women, we are kind of shamed into hiding how we feel about everything. And Dr. McGee can talk about, the emotional toll and the psychological toll, but just from a real kind of, background about women, we are told to be ashamed of all of that. From the time I can remember, when I was younger, people would talk about being on the rag, and that sounds awful. That just sounds horrible.
Nobody wants to be on that. Nobody wants to be on that.
No. So it starts, I think, with that. And then when you start with that, and then, it was the worst thing that could possibly happen if you, mess up your clothes at school and, then you get teased and, they had all the names for, girls that didn't have their hygiene all together. And so I think it starts kind of from that whole prepubescent stage to kind of continuing beyond that. And so it starts with the boy snapping your bra on the playground, when you're in the 4th grade, to, he who shall not be named talking about grabbing people by the, what, so I think it's kind of when we start as women, we start with automatic shame, okay, about this whole thing, because our bodies, our sexuality, how we feel about ourselves has to all be wrapped up in how other people view us and how other people think we should be or should act or should present ourselves, right? Yep. And so I kind of think that it's a kind of a not just an issue in our community, but an issue everywhere for women. I think kind of more so in our community because, we're the mules that carry the load for
carrying the whole thing.
And so for everybody. And so I think women that are not of color kind of get to cry and get their way. We got to suck it up and move on. I mean, I've had patients who, have been literally hemorrhaging to the point of transfusion with fibroids and things like that. And they come in my office and say, well, the doctor gave me a depot and then they gave me an IUD and then they said they couldn't do anything else. And, I just don't know what to do. And I'm like, are you kidding me? Like there's a whole bunch of other stuff we got. Other than
Exactly. And, so the idea of just downplaying the facets that make us a woman, that make us uniquely a woman, we are encouraged to downplay them, right down, like you said, from, developing breasts to menopause. And so that's a really interesting point that you brought up, Dr. Lori, about, what is the emotional and mental toll of having to not be able to talk about it? Okay, you don't talk about that. Definitely don't talk about sex or babies, where they come. Just don't talk about those things. What is the mental and emotional toll of downplaying, minimizing, and really kind of being forced into hiding about things that we absolutely have no control over, right? So they're gonna happen. It's not something that you can, kind of be like, well, maybe I'll develop breasts, maybe I won't. No, you're gonna develop something, even if it ain't that much, right? So what is the mental and emotional toll of just not talking about it?
Well, I think the best analogy I can give is, there are commercials for Cialis and Viagra. If your penis is not functioning properly, you need to call your doctor. You need to tell somebody something, right? But there's no commercial that says if you're having hot flashes and mood swings and difficulty sleeping at night and you're agitated and, call your doctor to discuss what's going about menopause. And so I think once again, it's a societal thing where we, I have had so many patients come to me and tell me, that the doctor just said, there's nothing that they can do. And that this is just, I'm just getting older and, it's just because I'm a woman. And, okay. Yeah, it is because you're a woman, but we got something for that.
Right. We got something for that.
Lazy. Why you don't help the patient to find an answer or solution to the problem. Now, I think a very important piece to this, and I think Dr. McGee can speak to this, is normalizing the changes that you go through. Yes. So when you think that it's normal, when it happens to you, it feels differently. I'll give you a great example. So when I started my period, my mother had this almost like rite of passage for us where we went to dinner and we talked. It was like, you're a woman now. And, it was her and me and my sister. And we all went out to dinner and we had this conversation about having a period, how it makes us feel. And this is something that it happens every month, and responsibility comes with this. Like you have to keep yourself clean and you have to make sure you have your supplies and you have to make sure that you understand now you can become pregnant. Like that. Right. That's my mama. Yes, where I get it from. Get it from my mama. So, that's how it started at 14, right?
Right.
And so I did the same thing with my children, and they thought I was corny. Oh my gosh. But we went out with my sister has a daughter that's a year younger than my daughter. And so they had a period about the same time. So we all went out to dinner together, just the girls, and we got our nails done and we got our toes done and we went to lunch and talked about having periods and things like that. And so we are kind of making it a celebration of womanhood instead of being embarrassed or ashamed of.
Yes.
And so they kind of are now like, I'm a lady.
Right.
And so kind of they have a different sense of it, I think, than their friends do. And their brothers were like, huh? And they're like, I'm a woman now.
Right. Dr. Lori, this is so amazing because setting the tone, I think, from the beginning is going to impact them when they get to this stage, because they're not going to be like, all right, so this is another phase of womanhood. Not, oh my gosh, I'm entering the end of life, the change of life, So Dr. Rania, tell me. So while what Dr. Lori is doing is amazing, I think that there are a lot of people out there who are missing out on this nice little experience that she's creating for her young ladies. I did not get this experience. And I think a lot of us did not get this experience, right? So we're walking around with this, like I was talking about, the shame of minimizing what is happening to you. What is the mental and emotional impact of hiding that experience?
Well, I think it creates a lot, from my perspective, when these ladies come into my office, there's already a lot of anxiety that they're having because they don't have the words. They don't even know their body parts well enough to express what's wrong and why they're having the anxiety. So with me, because of the medicines I prescribe, a lot of times we'll have sexual side effects. And so I talk about sex a lot in my practice. But if I'll ask them, are you having an orgasm, or are you, getting aroused? They're looking at me like, oh my gosh, I don't even
Wait, are we on that
what you
kind of
asking me?
basis? Like, what's your
You-
wait? We on a
you
first
know,
name basis? Because I don't have these kind of conversations with
Right,
people.
right, right. And I have to, like, Dr. Gibbons said, I have to normalize that it's okay to know your body, and that
Mm,
alleviates a lot of the anxiety about having the conversation to say, yes, there's a reason that your libido is low. Let's talk about what a libido is. Let's talk about the fact
right.
that you should be having an orgasm.
Ooh.
And if you're not, we need to talk about why that is.
We need to
You
fix
know,
This is good. This is really good
fix
because
that.
these conversations are not happening in living rooms around America. Hello, how is your libido? Are you having
yes,
an orgasm? No, that's not happening. So, Dr. Lori,
no,
tell me. So, as we move, we transition from, we're beginning to we enter womanhood, then we experience the full range of womanhood. And then something about when we get to the perimenopause, it's like, womanhood, I guess, coming to an end. What's happening to the womanhood? Like, how do we define what's happening in our womanhood once we get to the perimenopausal stage?
Okay, so perimenopause, from a technical standpoint, is 3 years surrounding the time where you stop having periods, right? So, from a physiologic standpoint, you're going from a million eggs when you're born to running out of eggs altogether at menopause. So, that's basically what it is. When you run out of eggs and there's no egg to ovulate, there's no baby to be made, your ovaries are like, whew, I was tired, I'm done, right?
I was tired. Put me
I
in
tried. I'm
retirement.
done. And so, you had got a million out of me. I'm finished, right? And so
Mhm.
there is kind of a 3 year plus or minus time period surrounding that, the ovaries kind of, and giving out. So it usually, and I'll say in 85% of women, they have hot flashes, mood swings, sleep disturbances. They can be anxious, as Dr. McGee
Mhm.
eloquently discussed, and the lack of libido. All of those things go along with that 3 year transition process. Now, 15% of women continue to have these symptoms after menopause is over with. The most common symptom that continues, most common, right? I know, right? It's okay, though. It's okay. So the thing that the two things that are most common to continue is the hot flashes for some people and the lack of libido. And there's a simple explanation to that. Your ovaries produce testosterone, right? So that testosterone, as the ovaries give out and quit, they're like, okay, I'm retiring. I'm no longer working. That testosterone level drops to next to nothing. The testosterone is what's responsible for your libido, your sex drive. So in women, like, for instance, that have polycystic ovarian disease, that are really hairy women, they have way higher sex drives than women who don't have PCOS, because their testosterone levels are higher. And so when you get to the point where your testosterone level is next to nothing, you don't want to. I mean, and that's just the thing. And it's kind of nature's way of saying, you have done your job for society by trying to reproduce. And now you don't do that no more if you don't want to. Now, the key to all of this for me, and alleviating some of the anxiety that women have, is understanding that this is a normal physiological process. There's nothing wrong with you. Everybody is in this perimenopausal period experiences some level of all of these things. Now, when I have patients come to me, it's like, well, my sister, she didn't have flashes. Why am I flashing 8 times a day? Well, when you have that conversation with your physician, hopefully they're explaining to you that there's other issues that accompany those changes. Like, if you have higher body fat, you're less likely to have hot flashes. Okay.
Wait, slow down, stop, hold on.
Yeah.
Don't you speed on past that, because I'm starting to hear some good news in this story for me. So you said the more fat you got, the less likely of the hot flashes. Is that what you said?
Yes, they're usually less likely and less severe, because women who have a lot of body fat, there's a peripheral conversion of like androgen to estrogen in your subcuticular fat. So if you have more fat, you have more estrogen. So your estrogen levels aren't going to dive like mine will. You will have more estrogen on board, and so you're less likely to have that hot flash, right? Because it's your basically the receptors that cause the flashing and flushing, the vasodilation, is alleviated by estrogen, right? So if your estrogen levels are higher, you don't have those hot flashes. Well, but if you're like me and you already flashing, you understand, and I understand it. I know where it comes from. It's not upsetting to me. I wake up, and part of the reason why my hair is not done now is because I woke up this morning and my hair was soaking wet. My back and my neck was soaking wet. My leg was hanging off the bed and my gown was up on my neck. And my husband was looking at me like,
what is happening on this side of the bed today?
You all right? And he always like, babe, you okay?
Right.
Like, yeah, I'm good. But I had no idea. I did that during the night. Covers gone, leg hanging off the bed, you know, gown up around my neck like it was a necktie or a scarf. And I woke up and started soaking wet. Now, it doesn't cause me to have anxiety because I know where it comes from. It's okay.
Mm-hmm.
You know?
That's interesting. So you think that now I'm curious, so is the anxiety being caused by us, the lack of knowledge, the lack of knowing what to expect? Or is there actually, Dr. Rainier, some kind of hormonal change or something? I don't know the words, you know the medical terms, but is there something physiologically happening inside that's causing the anxiety? And I've shared my story before, and I'll share it again. Like 3 years ago. So that's why I'm really interested in this 3-year thing, because I'm trying to figure out what's about to happen, because I don't see things happening the way I'm reading in the books.
Mm-hmm.
But at about 42, things just started going way, way wonky, right? So 1 month I'm thinking, nah, G, no, we not about to have a baby. What is Flo? Where you at, girl? It's time. Where you at? And she just was chilling. Didn't come for a while. Then she just all of a sudden popped up out of nowhere. I'm like, wait a minute, what's happening? Out of nowhere, here she is.
Yeah.
Then she left. Yeah. Then she came back real soon. Like, it's just like wild stuff. Yeah. Like, okay, how do I plan my life around? I don't know what's going on with you, girl. Can you give me some? And I'm not getting symptoms in advance to give me, before you get some like warning sirens. Hey, probably now. Not getting no signs. Just all of a sudden, hello, girl, what's up? So, I mean, how do you kind of mentally prepare for just the volatility, the uncertainty around that?
Well, what I have to tell my patients is, Dr. Gibbons knows this well, what we tend to look at is more so a little bit what's going on with the estrogen levels. Because we know from our standpoint, estrogen is a beautifully complicated hormone and has specific operations within the brain. So it modulates serotonin, norepinephrine, dopamine, and those are 3 of the major neurotransmitters in the brain that affect mood. But that's also why we see people who have mood issues around their cycle, or have PMDD, or start to have these perimenopausal symptoms because their estrogen, even though it cycles throughout their life, as we hit that perimenopausal stage, sometimes I'll even draw it out. I'm like, yeah, she's getting low on us, and as she gets low, so do our neurotransmitters. So we'll see lower levels of serotonin, lower levels of norepinephrine, higher levels of dopamine, which means that we get more anxious, we get more sad, our libido will drop, we'll get fatigued, the insomnia will be such that that's what drives a lot of patients, from my standpoint, will drive a lot of patients being in to see me because they won't be able to sleep.
And when does the not sleeping part, like, is there sort of like, does it start early, or is it just range from, we don't know when that starts, but that could be a sign that we are entering menopause when you can't sleep?
Yeah, it's twofold, because from my standpoint, I have to look at someone who's already had a history of depression and anxiety. Because during perimenopause, they are more apt to have a worsening of their symptoms, or an exacerbation of symptoms that were already controlled. So that's where the education piece comes in, with knowing how to speak with their doctor about that. So I'll always tell my patients, girl, we've been stable for 6 years, but you are now 41, 42. So we need to be aware that we may be a little irritable starting to come up, where our insomnia might return. And if so, this is what's going on. We'll get this checked.
Rania, ain't nobody told me that, honey. And I'm telling you, no, seriously, like 3 years ago, my depression and anxiety reached points that I had never experienced in my life. And I'm thinking to myself, what's wrong with me? Like, and I'm doing all the things that I've normally done to manage these things that, I've gotten pretty good at managing, right? And then all of a sudden, everything went out the window. It was just the moods, it wasn't, I know you probably shouldn't use the word insane, but it was insane. And not a single, I went to, my regular physician, my therapist, nobody was saying, hey, you know what? This could very well be tied. No one said, hey, are you missing any periods? Are you stuck? Is it irregular or anything? Yeah. Nobody asked me that, because if they had asked me, I'd be like, yeah, that's interesting. I wouldn't think to tell my therapist that. My OBGYN, but not my therapist.
And that's where sometimes, as a physician, and Dr. Gibbons, we talk about this all the time, we treat the whole person.
Right.
So, I have to, even though I'm focusing from a mental standpoint, I know what's clinical depression. I know what's clinical anxiety, but I know what sets of questions to ask to differentiate between the vasomotor symptoms that look like perimenopause. And so there's been many a patient I've sent back to their primary care doctor or back to their OB-GYN, because I'm like, not only are they depressed, but they haven't had a period in 3 months and they're having night sweats, and those aren't things that I would see with depression.
Right.
And so it's being able
to distinguish,
to take the time to talk to your patients and ask them those questions, and to give them information too. So now hopefully people will know.
Yes.
To say, hey, I'm mad. I'm mad, but I'm sweating at night and waking up. So what's going on?
And I will tell you, somebody told me to ask about my estrogen levels. This wasn't a doctor. This was like, hey, you might want to ask about your estrogen levels. And I was told by my physician that because the estrogen levels fluctuate so much during the month, that her checking my estrogen levels wasn't going to give me really any information. So she didn't.
Yeah, that's true. That's true.
Okay.
From an OBGYN standpoint.
Well, I'm happy for her that my Spelman sister confirmed, because I was like, is she about to tell me that she lied to me?
Okay. But taking it a step further, and I love Dr. McGee, because she is just like, we are like nodding our heads because we know that we are here. Because, what people don't understand is those hot flashes that cause the lack of sleep, you cannot be a balanced, even-keeled individual when you don't get sleep. You can become anxious and even paranoid if you don't get enough rest. And so
psychotic.
Psychotic, exactly. What people think is actually a psychiatric-based disorder is actually disorder based in physiology. And the beauty of it is that if you are hot flashing and that's what's keeping you up at night, guess what our number one drug of choice is for patients with a uterus that have hot flashes? I bet you will never guess. Selective serotonin reuptake inhibitors. Your Zoloft, your Prozac, your
antidepressants.
Yes, antidepressants decrease hot flashes by 50%.
You got to slow down. Yes. So antidepressants are shown to help with hot flashes.
It decreases clinically proven and study proven to decrease hot flashes by 50%. And if that doesn't work, we go on to atypical antidepressants like your Effexor and your antipsychotics even can decrease hot flashes by as much as 65 to 70%. And so we start with the ones like Zoloft. It's so benign. in pregnancy, right? So
Yeah,
it's not a whole lot of side effects other than people like to eat on the love. So you gotta be careful on your love, okay? Prozac kind of knocks out your libido, so you want to be careful if you're on the Prozac. You might want to get the toys and have to talk with your husband, be like, hey, rub me right here.
Yes, and that's real. That's real.
So, it is one of those things where you have to tailor the management based on the patient. Now, getting back to the actual physiology, testing estrogen levels is really meaningless, right?
Mm-hmm.
The only reason why you would do that is, if you're doing a workup for polycystic ovarian disease, or if you're doing a workup for an ovarian tumor or something of that nature. But when you're talking about menopause, the lab work that you need is basically follicle stimulating hormone, or an FSH. Okay. Mm-hmm. Your FSH is basically your ovaries and your brain, your hypothalamus, the area in the brain right behind your nose that controls your hormones with your ovaries. They kind of communicate. But at the beginning of your cycle, they're doing this. And at the end of your cycle, they're doing this. And in the medical community, we call that axis instability. So your axis up here is not agreeing with the axis down there. And so that's why you get these ridiculous, I just had a period 2 weeks ago, and then I had a period for 6 months. What the world is going on? It's because your brain and your ovaries are no longer communicating effectively, because your brain is going, come on, and your ovaries are like, and there's only one egg or 2 legs left, and so they're getting pounded by your brain. Your brain is like, come on. So all this follicle stimulating hormone is getting released. So when you measure that in the blood, somebody who's menstruating, it's going to be like 3, 4. Somebody who's perimenopausal, it'll be 25.
Okay. Now tell me what the name of that. What is this test that we need to be asking for again?
FSH.
FSH.
Follicle stimulating hormone. So that tells you whether or not your ovaries are highly functioning or whether they're almost done. Okay. This is a test we do for patients who are having fertility issues. We also do that for patients who think they might be menopausal. And it's a much better test because it actually gives us useful information. Estrogen level, okay.
All right. Well, she didn't tell me about the FSH, so I need to figure out what I'm gonna do about that. So, we're gonna move the conversation along a little bit, because a lot of this stuff I figured out on accident. So let's just break it down. This whole dryness thing, okay? Yo, like everything is dry, like everything is dry. Okay, the hair is dry, the skin is dry, down there is dry, everything is dry.
Right.
What the world? Like, okay, first tell us what's happening. Why is this happening?
Okay,
make it brief, because we don't care that much. What we really want to know is what we can do about it. But we can start with so we can be informed.
Okay, so short answer: estrogen levels. Okay, low
this
estrogen.
Dang on estrogen is a mess.
Listen, Dr. McGee tried to tell y'all estrogen is very, very important. It's very, very important for women. Very
I'm starting not to like estrogen no more.
We're gonna stop right there. Okay. The good news is that vaginal dryness in your hair, skin, all those things can be treated. Okay. Yeah. First things first, though, we need to make sure that all your other hormones are in line. So the thyroid, which is right here in the neck, is a very, very important gland that is responsible for metabolism and dryness in your skin, your hair falling out, all those things the thyroid does as well. So we can't blame everything on estrogen. You have to make sure all the endocrine system as a GYN, we look at all of the endocrine system.
Yes.
So it's not just estrogen and testosterone, it's the thyroid level and all that as well. And so you can't negate that, because, and Dr. McGee will tell you, people have committed suicide that have had hypothyroidism, right?
Yes.
Their thyroid was so underactive that their metabolism, their mood, everything was depressed. The best analogy I can give you is droopy dog. Okay. Droopy dog, for the people in the crowd out there that are old enough to remember the cartoon Droopy Dog, The dog was like this. He was like, I guess I'm gonna. I mean, that's the thyroid and hypothyroidism. That's how you feel. You feel
Yes,
like you
yes,
can't move, you can't walk, you're
yes.
exhausted, you have no desire to do anything. And then what people do is go, oh, you're just having a hard time, you're just depressed. It's okay. Go see Dr. McGee. She's gonna fix
Yeah.
you, right?
What I'm doing is drawing a TSH level, and I'm checking your thyroid first, just to make sure before I
Wait, so
prescribe
your
you an antidepressant.
psychiatrists are, wait, okay, this is going to sound straight ignorant. Psychiatrists doing blood tests? Like, okay.
They are real doctors.
I mean, I'm not suggesting. I know she's a real doctor. Hello, I would not have had her on the show. Hello, we're gonna have one fake doctor, one real doctor on the show. No, that's not what we're doing today.
No, and I'll tell you why. Because part of it is the lack of education, and this is why your show is so beautiful in this sense. Because oftentimes, and Dr. Gibbons will tell you, with particularly with our community. So I'll just put it in our community. You know, we'll go in, we'll tell our doctor we're tired, we'll tell our doctor we're constipated, we'll tell our doctor we're oversleeping. They'll send it to me. No labs done. None. So I have to think, is this clinical depression? Knowing that systemically it could be hypothyroidism, it could be diabetes, it could be perimenopausal symptoms. You know, it could be a plethora of things. It could be Cushing's syndrome. I mean, it could be whatever. Right. And if I don't have that blood work in front of me, I have to order those things. So there's been plenty of times I've discovered someone was perimenopausal because I drew a FSH level, because I asked the right questions. And I'm like, yes, you may be depressed, but we also need to get you an OB-GYN. We also need to send you to endocrinology. So there's a lot of times that I will stand in the gap of a primary care physician because our patients and our communities just don't get there, or they don't get the level of care that they need before they come to me.
So let's just say,
absolutely.
So, I mean, because I'm listening to this, and in retrospect, now I'm thinking I should have asked for some of this stuff, because nobody was running any labs like that on me. I don't recall that. I know this FSG, that was not happening for sure. So that definitely didn't happen. That 100, I know didn't happen. So, you know, making sure that we're informed enough to know the right test to ask for, that they are testing our thyroid, that they are, you know, looking at this follicular FSH, you know, as we enter these, you know, 40s and up years, that these are other areas that we need to consider. And as a woman, you know, we need to not settle. We got to get, as we get more informed, not settling for, it's just that I'm tired, it's just that I'm having mood swings, all of this is normal. But in fact, actually confirming, you know, maybe some of it is normal, but is it, you know, but it could possibly be outside of normal. And again, because we're not talking about it, mama ain't tell you, granny ain't tell you, you know, all I ever heard about was hot flashes. That's what I thought. Oh, your period stops and then you get hot flashes. That's it. So when all this other stuff started happening, I was like, hold up, wait a minute, what's going on? And even, okay, so with the dryness.
I know, I'm sorry. I just want to wait for you. Wait for you.
We're sorry, doctor. Our bad.
And we're back. Okay, so the dryness really is to do with estrogen, right? But make sure that your primary care physician or someone checks your thyroid, because if you have hyperthyroidism or a spectrum like Graves' disease or something like that, you can have really like horribly dry skin that flakes and peels. Your hair will fall out, you know, all those kinds of things will happen. You'll have all this weight gain. And so we can't chalk all of that up to menopause, because menopause is not always responsible. Now, that being said, starting with the most important thing, vaginal dryness, let's just go there, okay? Because that's what I do, the vagina, right? So the vaginal dryness is to do with estrogen levels. But if you have a uterus, There is a way that we can stimulate additional production, even if you don't have a uterus, but it's one of the ways that if you do still have a uterus in place, we basically can perk up that vaginal area, cause you to produce vaginal moisture and all of those kinds of things without increasing your risk for uterine cancer. Now, the procedures that are done with that, let's start with pharmacologics first. So over-the-counter lubricants and things like that is usually where most people start. That's a good place to start. What I will say about that is I would avoid any gels. Okay. Mm-hmm. So KY gel in particular, if it's a water-based gel, when it hits air, it's going to become paste. Okay. So that is not going to help you. So if you use KY jelly, not really helpful. That's for teenagers that don't know what they're doing. Okay.
Right. I love you, Lori. I love you, Dr. Gibbons.
Just saying.
Yes.
Thank you. Okay. All right.
So for adults that are having
grown folks
estrogen issues, you want to use KY ovules. They're inserts that you can put in your vagina that melt over like a 3-day period of time. And they give you kind of vaginal moisture over like 72 hours. Okay. So you get a good 72 hours of vaginal moisture. So if you're going on vacation, girl, get your KY ovule, put it in there before you leave, and that'll give you moisture for 3 or 4 days. Okay. Mm-hmm. So that's a good place to start. I like those. They sell them everywhere. Okay. Any drugstore, any, superstore. Okay. I'm not endorsing anybody, but I'm just saying they sell them everywhere.
Yep. Gotcha.
So the next one, if that doesn't work, then I would go to your silicone-based lubricants like Astroglide. And my disclaimer is I have no stock in any of these companies. I have no interest other than moist vaginas in this conversation, right?
Thank you.
So Astroglide is phenomenal. I say to you, if you spill that stuff on the floor, you better find it and clean it up before you slip and fall and break your neck. Okay?
Wow.
Yes.
That's free. It has microscopic silicone beads that slide on each other, right? It's like a clear liquid and it's real thin. A little dab will do you. 3-4 drops is all you need, okay? Because it comes in a little teeny tiny bottle because you don't need that much, okay?
Got it.
Phenomenally. And usually my younger patients, in the 40s and 50s that are menopausal, it works really well. Now, the tougher to treat patients that are usually my over 65 ladies or women who have had hysterectomies very young and haven't had any estrogen replacement therapy, okay, then there's a step up from there. So let's stop right there. So women who've had hysterectomies for whatever reason, fibroids, ovarian cysts, endometriosis, those kinds of things. So if you've had a hysterectomy for those reasons at a very young age and your ovaries were taken out, which, by the way, do not let people take your ovaries out if they're not diseased. Don't do that. There's a study that came out in 2013 by the American College of Obstetrics and Gynecology that says that to decrease your risk of ovarian cancer, we take the tubes out, not the ovaries. The tubes, not the ovaries. I'm going to say that one more time.
Tubes, not the ovaries. Tubes, not the ovaries. Okay.
Do not let your OBGYN take your ovaries out if there's no cyst or disease process involving the ovary. It is not going to decrease your risk of cancer unless you are gene positive. So BACR 1 or 2. Okay. The people who are gene positive for hereditary breast and ovarian cancer do need to get their ovaries out. Everybody else needs to keep theirs. Let me ask you a question. How many men will sign up to get their testicles taken out? Anybody? I don't hear anybody. Okay.
Come on now.
Right. So the reason they don't do that is because it severely affects everything about your bone loss, your sex drive. That's how you make a unit, is to take testicles off of a man. You create somebody who has no desire for sexual activity. Right? So why would you do that to a woman? Because we don't care if women have sex. Once again, that's a societal issue. So we need to advocate for ourselves and say, I really want to keep my ovaries. I don't care if I'm 45. I like them. I want them. Okay. So once again, if they're not diseased, and if you have ovaries that, one has a big cyst on it or something, have them leave the other one. There's, leave the other one in there. There's no reason to take it out. So in those women who have had their ovaries removed, it is okay to do estrogen therapy. Now, there are wonderful formulations of estrogen replacement these days. The last on my list is estrogen cream because it's messy and sloppy and gross. So that's the last on my list. Okay. I much prefer, there are rings that you can use that you can put in your vagina that estrogenate that tissue and cause you to have vaginal moisture and thicken up the tissue to decrease your burning and irritation with urination and with intercourse. Estrogen is what it's called. There are estrogen patches that have gotten to be this size, like super small, like quarter size, Bibel dots and things like that are awesome. You can hide them all kinds of really cute places. And so they work really well.
Yes.
Estrogen so that you don't have the vaginal dryness and all those other things, swings and everything else. Another formulation that I like is Eva Mist. It's a little bit of mist that you just squirt on your arm, right? It comes in a little, almost like a little foghorn, and you just put the thing on your arm and you just boop, boop, pump it. And that's it, right? You do that once a day. It gets absorbed through your skin and it works very well. The only thing I would say about that is if you have pets that like to climb on you and you pet them a lot, be careful because the estrogen can transfer anything or any being that touches the area of your skin where you have put that estrogen. Okay.
So then we got a veterinary visit coming up.
Okay. So that's that. Now, moving along to the patient who, for instance, very good patient would be your breast cancer survivor that had her, who was PRCA 1 and 2 or 1 or 2 positive, and she had to have her ovaries removed to prevent ovarian cancer at 38, right? That patient is going to have a much more severe case of vaginal dryness and atrophy. We even call it lichen planus, lichen sclerosus. We have all these names for this kind of severe vaginal dryness and thinness. So what I would say with that patient, because they're not a hormone candidate, there are procedures like everybody's heard about the Mona Lisa Touch, which is a laser procedure, Fem Lift, which is another laser procedure. The procedure that I do is Thermiva. And these procedures basically are heat procedures. So you heat up the tissue of the vagina, you activate the neurotransmitters, which stimulates blood vessel production, and it also stimulates collagen formation, right? So you basically are reversing the aging process in the vaginal area without hormones. Okay. Wow. And all of these desperate housewives or whoever and wherever, that's what that is. Okay. That's vaginal rejuvenation is kind of like the trendy garbage term that we use, but it actually was a procedure that was developed over in Europe to treat urinary incontinence. Okay. That was the real doctor stuff.
Wait, I got a question.
Yes.
Is that a side effect? Like, is that a side benefit of getting that particular type of treatment? That is going to help with the urinary incontinence. So you literally killing two birds with one stone.
It is the reason that the technology was developed. So it was developed by urogynecologists to treat urinary urgency, frequency, and leaking. Mild to moderate urinary incontinence can be treated with any of these heat procedures. Okay, that's why it was developed. Right? Dr. Alan Saad in California is the one that developed the Thermiva. And I particularly like that one because the probe is probably about the size of my finger. The probe for one of those Mona Lisa Touch procedures or one of the procedures that it's almost like the size of the bottom of a tennis racket so it's about, I got some markers on my, so it's about twice the circumference of this, twice the circumference of a quarter. I
got you. I got what you're saying.
And so if you're already having issues with vaginal dryness, you don't want
that rolling up. No. Right? You know what? We have a couple of questions too. For sure. I want to thank y'all for the questions. I see y'all out there. I'm on a whole new platform I ain't never used before. I don't know what's happening. All of a sudden, I got questions, y'all. So thank you so much. So Hope Demps has a question. She says, do I get hey, that's our classmate. Hey, Hope. This is great information. Do I get estrogen levels tested by my PCP, or do I need to go to an OBGYN? or does it matter? Now, I thought you said don't do the estrogen test, right? Okay.
Yeah.
Clarify what she should get. She should get
FSH.
FSH.
Very important. Very important. It's a time study. Day 3 of your cycle. If you're still having periods, you test FSH on day 3, because that's how you compare every woman in the world that's ever had an FSH. You do it on day 3 of the cycle. Day 1 is the first day of your period, right?
Yes.
Day your period is day 1. You want that FSH on day 3 of the cycle. Very important.
That is good stuff.
Yes.
Man, Hope is all into this. You know what, Hope? I ain't mad at you. See, there was some personal motivations for me doing this show so I could ask these questions for y'all, for me. So I'm not mad at you for asking all the questions, Hope. I'm not mad at all. So she's asking, and I wanted this too. What is the Mona Lisa touch? Is it one of those kind of vaginal rejuvenation type procedures?
Yes, it's a laser. It's a laser procedure. Okay. And I said, I don't like it because of the caliber of the delivery system. Right. And the fact that I've done both, right? And the patient, when they get a Mona Lisa or a fem lift, or, there's lots of different lasers, they kind of do the whole thing. So it's kind of like being popped by, one of my patients said, a hot rubber band about 5,000 times.
Oh my goodness. Child, stop it. You already struggling. You already told us we got anxiety. We got hot flashes. We ain't sleeping. And now you go pop us with a rubber band, 5,000. Child, stop it.
But the deal is this. Let me say, to be clear, it's still a really good procedure because it's over with really quick. Okay. So it's just like pop, 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 and you're done in like 30 seconds to a minute. It doesn't take long. Okay. Now, the Thermiva, is a radio frequency procedure, which is basically less energy. So it's not hot, right? Like it's hot, but it's not hot. It's hot, like hot tub hot, not like laser hot, right? And so you don't have a zing, ping kind of sensation. It's just like, it's a windshield wiper movement with the device. So somebody's just kind of like rubbing you in your vagina for like 10 minutes. So it takes longer, but it's not painful at all. You don't feel no pain. For the provider, it's more time, right? Okay, so you spend more time, but I just talk about, what's the last movie you saw? And
it's over. Yeah. Because who you choose as your physician matters.
Oh Lord, yes.
Right? You want to have somebody who understands. I mean, who's not going to just be like, "Oh, girl, everybody got menopause. You'll be all right. Wait a few years.
You're just old.
It's okay." And I think, that's been kind of my experience. It hasn't been one where, somebody sits down like you did with your young children, Lori. That's what I felt like I needed. The remedial course. Nigel, your life is not over. You're entering into a new stage of womanhood. Yeah. This new stage of womanhood looks like this. Where is the what to expect when you're menopausing? Where is that? Like,
girl, don't have another business.
That's what I'm talking about. But this is important information because I'm telling you, I could have avoided a lot of stress and just issues because I could have been targeting some specific areas that I didn't know I needed to target. So I thank you, ladies, so much for this information. So Dr. Rania, you know, I like to talk about the mental health and how we keep from going crazy in the middle of all of this. What can we do, girl? Because I hear physically, physiologically, and what we can do medically to kind of help with the physical manifestations of what's happening to us. Dr. Lori gave us some amazing information around just not knowing about the depressants, helping with the hot flashes, the what was it, the KY ovules. Child, I do not know what's happening up in the contraceptive section of the store. I need to get more informed.
You need to come and see either me or Lori because we talk about sex all the time.
At this point, I need to make a drive somewhere because I am not in the know. Okay, so we're not even going to deal with that. So help us, like mentally. What do we need to be doing in terms of protecting our mental health while this is happening?
Okay, so first off, like I said before, if you have had a history of clinical depression, clinical anxiety, if you have a history of bipolar disorder or, psychotic, schizophrenic disorders, if you've had those in the past, be aware, talk with your doctor when you hit 35.
35.
Go ahead and start broaching that conversation because some women go early. So at least be aware, number one. So I would say that if you have a mental illness or have had one in the past, bring it up. Talk about it with your OB-GYN. Talk about it with your primary care doctor as you're going into these sessions. So step 2. Now, this is really about lifestyle because here's what's going on at the same time. Estrogen, progesterone, everything is changing, fluctuating. Our lives are changing at that time. Our children are getting older. Some of us have children who are graduating college and some in high school and some in middle school and some who are 2, 3.
No, not the 2, 3. But I was with you right up to middle school and having a college student. I was with you.
Trust me, I have some patients, they're 45, 46, and they've got a 1 or 2-year-old.
Absolutely.
They're trying to manage that. They're trying to also work full time, be, a spouse. And here's what I am seeing. They're also trying to now take care of their parents or older family members. And that's an additional stressor that's coming alongside all these hormonal fluctuations and mood changes. So I say all that to say this, to protect yourself, limit your stress and take some things off your plate. I had to catch myself. This is not the time to be trying to deal with foolishness at this point in your life.
Hallelujah. No, ma'am.
Yeah, honest. And I say that because from a biological standpoint, remember, we're talking about serotonin levels. We're talking about norepinephrine levels, dopamine levels, all of which are fluctuating, all of which are things that the brain need to give us our sense of resiliency, our ability to deal with stressors. So if we're already functioning at a deficit because of what estrogen is doing, we're making it much harder for us to deal with what's on our plate now. So if it's not vital, if it's not important, some of this stuff has got to go.
Wow.
Yeah. And I mean, that is the biggest piece I would say right now, because not only is your body changing, the aspect of where you are right now in your life is changing because we're in our mid 40s, mid 50s, stuff is different than it was in our 20s.
Absolutely.
So I would say that be aware of your past history and look at your lifestyle right now and remove what is not vital while you're dealing with these symptoms. You got to cut some things loose, and you may have to cut some people loose.
Likely both. Just saying. Hey, I'm just saying. Like, this is not this. You got to be real clear, right? On your boundaries, you need to be clear.
Yes.
What do toxic relationships look like? What do toxic jobs look like? What do toxic situations look like? Because this sounds to me like a perfect storm situation. You're thinking, hey, I'm just going through the change of life, like oversimplifying for one sentence situation, as Dr. Lori just explained, and you're explaining this thing got levels on
it. Has levels. If you're not, my worst case scenario is my patients who may have low level depression or low level anxiety that's been treated with psychotherapy. They may not even need a medication, but something happens to their parent while they're starting to go through perimenopause. They're no longer sleeping and they're fatigued and their focus and concentration is off and they're not focusing at work and they're trying to catch up. And if they don't sleep, I have seen people become fully psychotic through perimenopausal symptoms. So when I say manage your life stressors, I'm not being flippant by any stretch of the imagination. I'm saying protect your brain chemistry.
Wow. We could end the show right there, honestly. Right there, because Dr. Radia just told y'all, get your life right. Because
come on.
make it difficult. You're going to be dealing with a situation that is already kind of volatile because of what physiologically that you don't have no control over is happening. And add on that, you got dryness, so you may not be having relations regularly, which can help you.
Which is a stress reliever, by the way.
Yes.
You're not
Yes.
stressed out.
Yes.
Get your mind right and keep your circle tight. Okay, that's what you got to do during menopause, right? Because the people who are inside the circle of trust will know that if she's acting crazy, she's tired. Anyhow, right?
Oh, y'all are too much.
I love say, "Oh my God, can't stand." Well, it's just like a perfect example because I will admit I'm in perimenopause. I'm flashing all the time. It's fine, but I'm
in a patch. So what's the difference?
Listen. So, but the thing is, I realize that I'm just less tolerant of foolishness. It's not a change in me, right? I was more tolerant of it when I was younger because I didn't have so much going on, right? And then I got on top of that, I'm an OBGYN who doesn't sleep on top of not sleeping when I'm supposed to sleep because I'm flashing all the time. And you're going to come at me with some foolishness, and then you're shocked when you get what you deserve. Okay, so what you have to do, as far as I'm concerned, is relinquish yourself from the guilt of that. I see so many women come to my office and I think I need an antidepressant because I'm just so snappy. I'm just so snappy, especially the Southern women, right? I'm not gonna pick on us, but I am one, so I just don't say it. So I just can't. And my husband just says I'm snappy, and I said, "Well, how's your relationship with your husband? Are you good?" And she's like, "Well, we're separated right now because, I caught him doing some things that he shouldn't do. But, we're working through that and we're doing therapy." And I said, wait. So you're snapping at him. Now, what was the conversation? And so I take time and I said, well, what was the conversation? Well, he was hiding his phone from me and I couldn't see what the text messages were. And it was just making me upset. And so I just grabbed the phone from him. And I was like, so that sounds like a normal reaction to me. I'm not one to advocate violence, but what I'm saying to you is you are being provoked, right? So at some point, it's like the whole, especially with Black women, I'm in a corporate environment in my institution where I practice. And we are so caught up in not being labeled as the angry Black woman. Like it is some kind of albatross around our neck. Like we got a scarlet on our chest, angry. And we spend half of our day trying to convince people
that we're not angry,
that don't know us at all, that we're not angry.
Right.
And it's so funny about 45. I just hit this point where I'm like, she's not in my circle. She does not know me from campaign. What do I care whether it was just like a moment of complete freedom. I just free from that moment on because I'm a very even-tempered, level-headed individual, right? But you have to teach people how to treat you. And part of setting boundaries is no is not a curse word. Okay.
It sure isn't.
In any form, unless you're screaming it, right? And so if I say, and they said, well, Dr. Hims, we're just going to push your case back to 9:00 because such and such. And I go, no.
Nope. No. And you can even do it with a smile. Yes. This is so good, though, because for the last month, I have been going live. It was supposed to be every day. Now, then it became every other day. And it was every 3 days. Now it's once a week. Anyway, we're not going to deal with that. But I've been talking about self-care and that self-care is not about bubble baths are nice. Bonbons are nice.
Ain't nobody got time for that. I ain't got time for that.
No, self-care is about the way you care for yourself every single day. It's not about some event or activity that you run off to, right? So we've been talking about how do you set boundaries? How do you create checklists? How do you create processes that help to make your life one that looks like one that you actually do care about yourself, right?
Yes,
So
yes,
this
yes.
is really a mindset issue that so many women are struggling with. And now from what you ladies have so eloquently and amazingly shared tonight is that it's even more important as we enter 35 and up and we go through this next phase of womanhood where this is not an option. Self-care is not an option at this point because your body is almost working against you at this point. It's working against you staying sane. And so if you don't look at that proactively, you're going to wind up like me in a reactive situation where you're like, hey, what? Hold on. I know everything is what's going on. And that's what I don't want to see my sisters going through. And so you ladies have helped tonight shed some light where there was complete darkness for many of us, including myself. I was like, I thought I knew. I'm going to be honest. I rolled out here thinking I knew a lot.
and I know we've been on for a long time, but I will say this, as I was thinking about what else we could do, Naja, and Lori, as we're friends, keep your sister circle close. At this point, this is where we need to be talking to each other and saying, girl, are you feeling this way too? Am I feeling this way? People that you trust, because we're all in this age limit, this age right now where we're all experiencing this. So don't keep it to yourself and think that it's just you. I guarantee you someone else is feeling the exact same way. So don't be ashamed to talk about what you're feeling, because that is going to be the biggest point. So just to say that, don't be afraid to talk about it. It is not a bad thing. Give your body the honor that it's due. Yeah.
Last time I had you on the show, you cut up with a quote at the end that was so mic dropping that like my jaw was like, okay, there we are. So so now tonight you're telling us, what did you say? Treat your body with the what? What did you
the honor that it's due.
That it's due. Okay. All right, you're right. Treat your body with the honor that it's due, everybody. That's what Dr. Rainier said tonight. Treat your body with the honor that it's due.
And Lori, can you and I like to add this is my
I was coming straight to you.
Get your mind right. Keep your circle tight.
Get your mind right. And we're not just talking about circle of friends. All the circles.
That's right.
All the circles, guys. All the circles. Read between the lines. We're talking about circles. Anyway, y'all, this was amazing. I cannot thank you enough. I want y'all to know, you need to go back and listen to this. They were dropping all if you are 35 or older and you didn't listen to all of this, I'm going to need you to go back to the beginning and start at the beginning. Genesis all the way through Revelation. That's what happened tonight on the show. I'm telling you, do not miss out because I said
to menopause from the beginning to
the end of our womanhood. We are dealing with it all tonight. But these ladies, if you could not tell, it is special when you are a Black woman being treated by another Black woman. I'm just telling you, I don't know if I'm supposed to say that, but I'm just telling you my experience and what I just witnessed here. The fact that these women are so compassionate, so thorough, so looking out for you as a total woman, as you are looking for a physician for yourself. Someone to treat you. Black people treat. I'm just saying, you want to go on these ladies' website that they have created so that you can find more women like them that are going to be honest with you, compassionate with you, and give you the full picture about what's going on. And they have founded a site called blackpeopletreat.com. If you are a physician listening to this show, go sign up. You need to be on blackpeopletreat.com so we can find you there. Yes. If you are a patient which all of us over here, if we 35 or older, we already heard tonight, you need to be on somebody's chair or in somebody's stirrups having conversations about what is going on with you at this age. And so you need to go on blackpeopletreat.com as well. I love y'all so much. I can't even tell you. This has been one of my absolute favorite shows. I'm trying to figure out what topic I could talk about to bring y'all back. So we have to brainstorm because this was just too much fun for me.
Don't set us loose. There's no telling what we'll talk about.
What we gonna talk about next, y'all? Listen, I just want y'all to know Dr. Lori on call, so she might have to go deliver a baby in the midst of all of this. But
I've been looking at my phone like, okay.
See, the babies knew. The babies knew that the mamas needed the information. The mamas and the grandmamas needed the information because at some point, you know what I'm saying, we're gonna need this information. Y'all, thank you so much. I cannot thank you enough. Dr. McGee, Dr. Givens, it's been amazing. Y'all listen to the show. Check out our self-care videos if you haven't, because they're telling you we need to be doing self-care. Go on blackpeopletreat.com. Find Dr. McKee if you in South Carolina. Find Dr. Givens if you in Virginia, North Carolina. And if you are not in either one of those places, go on blackpeopletreat.com and find you a Black doctor. I love y'all. I am Nigel Drake, founder of Spark Her Blaze, where we empower women to spark their flame so that they can blaze their uniquely divine trail. And we hope that you got so much out of this tonight. Share it with your friends, y'all. Sharing is caring. Do not keep this information to yourself. I know you got friends that's 35 and up. Hit the little share thing. Share. That's all you got to do. Once they listen, they're going to be like, girl, thank you for this information. Y'all have a good night, and we will chat again very soon. Take care.
Bye-bye.
Thank you, ladies.
You're welcome.